Yeah, thanks a lot for the invitation. It's a great honor as a thoracic surgeon to be invited here and speak in front of this audience. For me personally in Bangkok, it's coming back since I was already here as a student doing a 1 month clerkship. And actually, I was able to do my very first appendectomy here, which was an experience that would never have been possible in Austria and certainly motivated me to go on with a surgical career. So this is the place at Vienna General Hospital where I'm currently working. And as we all know from the Nelson trial and from several other trials, that lung cancer screening, and this is the whole idea, leads to a considerable stage shift in lung cancer patients. And those patients who are actually having nodules in the Nelson trial, more than half of them had multiple nodules. So it's an important issue also for thoracic surgeons to consider. So I will first of all talk about risk estimation in multifocal nodules, then we'll focus on the surgical workup and staging strategies, and then briefly a few details on intraoperative localization techniques. We've heard a lot about the definition of nodules and the importance of differentiating solid versus subsolid nodules with partially solid and pure GGOs. Beyond the radiological criteria and risk factors for malignancy, which we heard a lot about today already, there are also several clinical risk factors like age, cancer history, tobacco use, smoking cessation, parenchymal disease, asbestos exposure, and our environmental factors that are equally important to take into account for estimating risk malignancy. Does the multifocality of nodules detected in a screening setting have any impact on lung cancer probability? If, according to the data of the Nelson trial, it does not. So having more than one nodule does not necessarily increase the likelihood of having lung cancer, but each nodule has to be rather analyzed individually, independent of the presence of other nodules. These data have also been corroborated by a recent retrospective large Chinese analysis, which basically came to exactly the same results. That's why also in the guidelines, while management of multiple non-solid or solid nodules is mentioned, but in the end, the management depends on the measurement and on the radiological characteristics of the largest nodule and is not influenced by the multifocality per se. If we look at the NCCN guidelines, which are the most frequently updated, the recommendations base more or less purely on size measurements. This is a discussion we also had just before lunch, and this is true for solid nodules as well as for part solid nodules as well as for GGOs, and do not take into account volume doubling time, which has been utilized by European centers for risk estimation more frequently. So basically, all of these guidelines only take radiological parameters into account. However, I think it's very important also to take patient-related factors and clinical factors into account, just like, for example, the F3 guideline, which is mentioned here. That's the German version of the guideline, which takes into account the risk estimation clinical factors as well in solid as well as in subsolid nodules. So how does the transition from the screening program after an adequate risk estimation is made work to surgical workup and staging? I think it's what also has been mentioned in the previous talk of crucial importance that a close collaboration between sort of a lung nodule board or a multidisciplinary evaluation of the patients with lung nodules is done. And good data have been reported, like here in this publication from the Mass General, and also as we heard in the previous talk. AI is an incredible aid in estimating or in judging the radiological appearance of nodules, and it's really fantastic what has been reported here, that it performs well even as the first reader in the UK trial, and I think the widespread implementation of AI is of crucial importance. However, for the decision making, which nodules actually should be worked up surgically or not, multidisciplinary evaluation based from the clinical side is of crucial importance. In 2023, European guidelines by both the European Society of Thoracic Surgeons as well as the European Association of Cardiothoracic Surgeons have been published, focusing on the management of subsolid lesions, and with the focus of multiple subsolid lesions. And the clear recommendation is that a sublobar resection, either by wedge resection or segmentectomy based on the dominant lesion, should be performed. If it's a pure GGO and it's central, then usually a segmentectomy will be the resection strategy. If it's a peripheral lesion, then a wedge resection will be done. And for part solid nodules, usually segmentectomy together with a mediastinal lymph node dissection are warranted. Then the European guidelines also focus on localization techniques, the importance of minimally invasive surgery, the importance of nodule assessment in a multidisciplinary team, and to first obtain the histology by the least invasive method available. Basically, it's a class 2A recommendation that the management should be based on the malignant risk of the dominant lesion, and a class 1 recommendation that a parenchymal sparing strategy should be performed. The North American guidelines were published shortly thereafter and basically confirm what the European guidelines also have said. It's when a biopsy is indicated in patient with multiple subsolid nodules, the biopsy should target the dominant lesion. And in case of multiple lesion, also multiple treatment modalities are feasible. Surgical resection of multiple lesions is warranted if the location allows it, and if a balance between the amount of lung parenchyma resected and the lung function of the patient and the overall clinical status makes this feasible, and other treatment approaches like radiation of other nodules might be applied as well. The equivalence of sublobar resections for lung cancer smaller than 2 centimeters it has nicely been established by 3 prospective randomized trials, which showed with variation in the details of the outcomes, but basically confirmed that segmentectomy and in specific situations, even a wide wedge resection together with a lymphadenectomy can provide equal results compared to a lobectomy in these small tumors. And from the technical aspect, we have clear consensus within the surgical community how a segmentectomy should be performed according to minimal standards. Once the diagnosis of a multifocal lung cancer is established, it's important to differentiate 4 clinical situations because they carry important therapeutic as well as prognostic information. And this has been included in the already in the last TNM8 revision of the I-ELCAP. It's important to differentiate secondary primary lung cancers from separate tumor nodules of the same tumor. Then thirdly, the situation of multifocal pure ground glass or lipidic lesions, or the diffuse pneumonic type of lung cancer, and also report that appropriately in the staging. So how do we differentiate between secondary primary lung cancer independent of the other tumors or metastasis? It's not only based on radiological assessment alone, but also on clinical risk factors, and particularly on the histopathological comparison based not only on the immunohistochemistry, but also on genomic testing, molecular and genetic analysis are of particular importance for that. And all of these factors have to be integrated and a decision to be taken in a multidisciplinary approach. So when analyzing the genomic and immune heterogeneity of multiple synchronous lung cancers, not really a lot of data are available. Here is an example of a nice paper published in a cooperation between Shanghai and London, looking at 16 tumors from 8 patients. And it could be seen that even though the tumors shared a few mutations, clearly the genomic and immune profile was different, indicating a different background at different developmental stages of the tumor as well. And this is something where we have to learn a lot about, because there is also some heterogeneity between different tumor localizations and sites within the same tumor. This is an example from our lab. It's not exactly corresponding to the to multifocal lesions, but it is an analysis in patients with small cell lung cancer between primary tumor and lymph node metastasis, where even though the molecular landscape is similar, there are differences in the expression of different markers and subtype distribution. And this is something that has to be taken into account when analyzing these data. So basically, with regard to long-term outcome data, we know that the surgical strategy of sublobar resections for multifocal lung cancers works very well with reasonably good outcomes. Pneumonectomy is, of course, something that has to be avoided in these situations, and usually a management with sublobar resection is perfectly fine. And particularly since long-term outcome rates of patients with lung cancer become better and better, the development of second primary lung cancers after the first lung cancer, which can again manifest as multifocal lesion, becomes a more and more important issue in lung cancer survivors. This review in the European Respiratory Reviews nicely summarizes the importance in future studies to really obtain matched tissue samples from multiple lesions to get a better understanding of the linear collections and the developmental processes in multifocal lung cancers, and to better guide our treatment decisions in that aspect. So last but not least, I want to share a few details on intraoperative localization techniques of multiple lesions. Basically, we have a variety of surgical techniques or interventional techniques available. There's the possibility for percutaneous marker placements with hook wires, microcoils, hydrogen plugs, or the percutaneous injection of liquid agents to detect the lesion. We can use intraoperative ultrasound, navigation bronchoscopy, and ideally, all of these settings are applied in a hybrid OR, which is only available to a minority of thoracic surgery, but this would certainly be the ideal setting. This is what a hybrid OR looks like. Here's an example of localization of central nodule by ENB, and thereafter by fluoroscopy, nice localization of the lesion is possible intraoperatively. Combined strategies can be applied, like a dye marking on the pleural surface for easy video thoracoscopic identification of the lesion, then a central marker placement to ensure the lesion is entirely resected, and this can be done by fluoroscopy, as well as cone beam CT, which has been shown by this nice series of 90 patients from a Japanese group. And for example, also ICG injection and detection by VATS is feasible. So to summarize, in multifocal nodules, standardization in imaging analysis, as it has been discussed in previous talks, is of course important. AI will be integrated for this. Standardized reporting is crucial, and there has to be an integrated risk analysis and a multidisciplinary decision-making, taking clinical factors, radiological assessment, histopathological comparison, and molecular and genetic analysis into account in multifocal lung cancers, and surgery should be performed in dedicated centers according to evidence-based guidelines. Thanks a lot.